Hello, everyone. Welcome to today's webinar, Medicaid Expansion in Utah. Before we begin, let's go over a few housekeeping items. If you're on the line and have not yet connected to the webinar, click the link in your confirmation email. Your browser may prompt you to download and run a file. When you're connected, you should see the presentation on your screen. If you have questions, you can send them via Zoom's Q&A function. Please take a moment and find the chat bubble icon near the bottom and center of the webinar screen. You can type and send questions throughout the presentation. We'll compile them and take time at the end for answers. When the questions have been answered, we will be giving away a gift card. Stick around because we'll be randomly selecting someone from the list of people still connected to the webinar. Also, mark your calendars. Other presenters originally scheduled to speak at the Provider Education Summit will be doing webinars in the near future. The next one will be The Weakest Link, Identifying and Vanquishing Compliance Risks by Robin Johns at MedUSA. She'll be speaking next Wednesday, April 29th at noon. You can register and see additional upcoming events at uhin.eventbrite.com. That is uhin.eventbrite.com. This webinar is being recorded and a copy will be made available to all attendees after the event. Now it's time to begin. Michael and RyLee, it's all yours.
Thank you, Sarah. Hi, so this is RyLee Curtis. I'm the Director of Community Engagement for University of Utah Health. And if any of you know me, I get very excited to talk about Medicaid expansion. In fact, I spent many years working on it as an advocate at a nonprofit called the Utah Health Policy Project, and then subsequently was the campaign manager for Proposition 3 to expand Medicaid in the state. Over the years, I got to know Michael Hales in his former position, so I will hand it over to him to introduce himself, and then we'll get started.
All right, good afternoon to everyone. We're happy to be able to join you, although we had planned to be in person in several of these presentations. We're glad we're able to present through this webinar format, and hopefully this will be informative to everyone who's participating in the webinar today. As RyLee and I have worked together in the past, she many years in the advocacy community, and I was for many years the state Medicaid director and was in that role during a lot of the development of some of the Medicaid expansion proposals that we will be discussing today, and then have been observing more from the sidelines, working in the provider community for the last several years. And we will be excited to go ahead and present. So should we move to the next slide, RyLee?
Yes.
Okay. Okay. So my first thought we wanted to kind of talk about, we'll go through a timeline in just a minute in more detail, but we thought these two pictures just kind of bookend a lot of the progress in in Medicaid expansion here in the state of Utah. On the left, you have Governor Herbert with some legislative leaders that were involved in trying to pass different versions of a Medicaid expansion proposal. This particular picture was back in 2015, as we thought we were getting close to actually completing a deal, and ran into many roadblocks that required additional discussions to happen during the legislative interim period that didn't really result in a full Medicaid expansion, but still resulted in some incremental efforts that I think were helpful to finally moving towards a final Medicaid expansion. And then RyLee, on your Prop 3.
Yeah, so, you know, Michael said it, it's been a long campaign to provide healthcare coverage for low-income adults here in the state of Utah, and we ended up moving this to the streets, as I like to say, and we collected the signatures needed to expand Medicaid. And through that, we went through the process of a ballot initiative. It was Proposition 3. It expanded. At the time, there was 3, technically 4 ballot initiatives in front of Utah voters that year. medical marijuana, Proposition 3 to expand Medicaid, anti-gerrymandering, and then of course you have the question on school funding. Proposition 3 passed with the most popular vote in the state. It was, only by a percentage or two, but we did have the highest percentage of Utahns voting in support of Medicaid expansion.
Okay, so as we kind of talk about what Medicaid expansion entails, we think a little background is helpful just in terms of the historical basis of Medicaid and how the expansion took place, what it means for people of different levels of income. So as we talk through this discussion, we will reference different percentages of the federal poverty level. So as a frame of reference, we include this slide so you can kind of see how a percent of federal poverty level works. So in the upper part, or maybe more midsection of the slide, we have the annual income, monthly income toward the bottom, but your percent of federal poverty level is going to be based first on the household side, household size, and then on the other part of the grid is what your income limit will be, and then that marks you to a certain percentage of the federal poverty level. So a lot of these discussions will center around 100% of the federal poverty level that we've got marked in the yellow column, and 133% of federal poverty level, which is in blue. So if you're an individual in a household, we're talking about $17,000 of income per year for 133% of the poverty level, or at the poverty level, roughly $12,700. But if you have a larger family size, the federal government allows a higher income to support that family and still be at a lower percent of the poverty level than a single individual household. So this is helpful, just background and framework in terms of the individuals we're talking about. And as we talk about full Medicaid expansion, we're talking about covering individuals with household incomes up to 133% of the federal poverty level. Then the other part of Medicaid eligibility has historically been a category of eligibility. So even if you were a low-income individual or an individual in a low-income household, if you didn't meet one of the categories of eligibility that are specified here on the slide, you would still not be eligible for Medicaid. So the historically eligible categories for Medicaid are children 18 and younger, pregnant women, elderly adults, people with disabilities, and a very limited number of adults with a dependent child living in the home. And as we have this discussion, we will be talking a bit about adults without children or adults with children. You could be an individual who has had children in the past, but those children are emancipated, no longer living at home, and you would fall into the category of adults without children, because it's more relative to whether they're living in the home or a dependent child. And historically, adults without dependent children in the home have had no eligibility for Medicaid, no categorical eligibility for Medicaid. Even if you had a very, very low income, you would not have been eligible for Medicaid. And if you were a pregnant woman, you see that your historical percent of the poverty level would be you're eligible for 133% of the poverty level from an income status. And then you would have situations where after delivering a baby, the woman would stay on Medicaid for 2 months. And then after that, she would be measured against a standard of eligibility as an adult with a dependent child in the home. And you can see based on this graph that that would drop her allowable income down to 50% of the poverty line. So you would have a number of women who would be eligible for Medicaid for the duration of their pregnancy and for 2 months after, but then they would lose Medicaid eligibility if their income was between 50 and 133% of the federal poverty level and would have no coverage just 3 months after delivering a baby. So these are some of the categories of eligibility and the historical percent of the federal poverty level that they had been covered at in Utah. With the Affordable Care Act, they were essentially trying to accomplish a policy objective that all individuals of low income would be eligible for Medicaid up to 133% of the federal poverty level. And then from 133% of the federal poverty level up to 400% of the federal poverty level, you would be eligible for subsidies in the exchange or the federal marketplace if your employer didn't offer health insurance coverage. So that was the original plan of trying to square a lot of this up. And this slide shows here on the left, in 2010, when the Affordable Care Act was passed in March, and they were planning for a 2014 implementation of Medicaid expansion and the implementation and advent of the exchanges. There was the option for a state-based exchange, or if you wanted to have participation in the federal exchange, that would be the option to the states. And the envisioned partnership essentially was everyone under 133% of the poverty level would be eligible for Medicaid, and then above that, they would be eligible for subsidies in the federal marketplace. But as most of you, I'm sure, are aware, in the summer of 2012, there was a Supreme Court decision that said the Affordable Care Act would not be considered constitutional as a mandate on states to expand Medicaid eligibility, that it would be a state-based decision. Because since 1965, when the Medicaid program was approved in Congress, it's always been viewed as this partnership between the federal government and the state governments. And the federal government lays out a pretty broad framework and then allows states to choose different levels of coverage and which populations they want to cover. And honestly, if you've moved around the country and been in different states and seen the different Medicaid programs, you'll see that some people might be eligible for Medicaid historically in one state and might move to another state thinking they would have coverage or coverage for their children, especially if they had a child with a disability, and then move to a different state and the program is different enough state to state that they are kind of surprised. So that's a very important aspect of the Medicaid program, is that state legislatures have a really big impact in their ability to design and implement the program in their state based on their funding levels, their interest in offering coverage, etc. So that was a good part of the basis for the Supreme Court decision in 2012. And so they essentially said Medicaid expansion is optional for states to decide. And then if the states choose to expand, then they could cover individuals with incomes up to 133% of the federal poverty level. And then the exchange subsidies would kick in above that. But for states that didn't expand Medicaid, the subsidies would be available for individuals with incomes from 100% and up to 400% of the poverty level. So this grid here just kind of shows how, in the green, the expansion of a lot of aspects of the Affordable Care Act took place. So first, for children ages 6 to 18, in our state of Utah, that population used to be covered under the CHIP program, but this made all children under 133% of poverty level eligible for the Medicaid program, and then CHIP became a coverage benefit for those incomes from 133 up to 200% of the poverty level. But the real impact for a potential Medicaid expansion was adults who didn't fit into the category of having a disability, being elderly, or for pregnant women. If they were just a low-income adult, maybe with a substance use disorder, they would not be eligible for Medicaid coverage. Or, as I mentioned earlier, a scenario where you have a woman in a low-income home who delivers a baby on Medicaid, but then a few months after she delivers, she loses Medicaid eligibility and loses her coverage. So the Affordable Care Act was really trying to eliminate categories of eligibility from determining whether people had access to health care if they were low income. So let's move to the next slide and kind of talk through a little bit more detail of how Utah's kind of wandered through this history, essentially a 10-year experience of trying to come to terms with what our decision as a state was and what's the appropriate level of coverage. As we pointed out, Affordable Care Act passed in March of 2010. We had the Supreme Court decision in 2012, and then you kind of had this ongoing debate about whether Utah would expand Medicaid. And early on, there didn't seem to be very much interest in expanding Medicaid. Historically, a lot of members of the legislature have looked at Medicaid as a program that's difficult to control its costs. They don't feel like, because it's an entitlement program, they have as much budgetary control as they would like. But I think as there were studies that started taking place in the summer of 2013, and the governor convened a working group during 2013, and a lot of the business community started saying, well, if we are going to be paying taxes to support this program, and part of the benefit that could be derived, acknowledging that some of those tax revenues would come back in the federal exchange as subsidies, but if part of the benefit that could be realized in our state would be by having a Medicaid match of 90% of every dollar spent on the Medicaid expansion, that could generate additional revenues in our state and economic impact, that there might be a benefit to this after all. So about midway through the 2014 legislative session, there were discussions about partial expansion, and that didn't seem to get much support. The governor unveiled his Healthy Utah program about that time, and it didn't get much support again during the 2014 session. But moving forward into the 2015 session, there was more momentum behind expanding Medicaid under the governor's Healthy Utah approach. And unlike a traditional Medicaid expansion per se, the Healthy Utah program said everyone under 100% of the poverty level would be eligible for a traditional Medicaid benefit through the traditional Medicaid delivery system. The individuals above the poverty level, between 100 and 133% of the poverty level, would be eligible for subsidies to go to the exchange and be treated very much like a commercially insured population. Would have been a little more expensive than insuring them through the traditional Medicaid delivery system, but that seemed to generate a little more interest from many constituencies who were willing to support the expansion known as Healthy Utah at that point. Eventually, the Senate did pass Healthy Utah. The House of Representatives was not willing to pass it. The bill failed in a committee hearing, and then the House sponsored their own version of minimal expansion of lower number of people with a less rich benefit. For those of you who are familiar with the Primary Care Network program, a program that existed in the state from about July of 2002 until just about a year ago, when the first part of the Medicaid expansion took effect in April of last year. It covered certain preventive care services, but didn't cover any inpatient hospitalization, no specialty care, and a limited number of prescriptions. So it was an attempt at trying to avoid high-cost hospital care, but it was clearly a limited benefit package. The House of Representatives back then was looking to maybe expand that program, and then the Senate didn't take up the Utah Cares, as it was known, piece of legislation. So we were essentially at a stalemate, and that's kind of back to that earlier picture in our presentation where you saw the governor standing with several legislative leaders, the Speaker of the House, and the Senate President, and Representative Dunnigan and Senator Shiozawa, who were the sponsors of most of this legislation in the House and Senate. And they convened a working group known as the Gang of Six to try and come up with some different ideas about moving forward, hopefully in the 2016 session. The recommendation out of the Gang of Six was essentially to tax all provider groups. The hospitals had demonstrated a willingness to come to the table and help pay for part of the expansion. Other provider groups were less interested in doing that because there are different economics in terms of Medicaid expansion to different types of provider groups. And because of that, it kind of hit a roadblock of sorts in terms of an expansion program. But in February 2016, there was a partial expansion that took place and created a program today known as Targeted Adult Medicaid, or the TAM population. And this is for, again, childless adults, no dependent children in the home, with very low incomes up to 5% of the poverty level, but who have some type of underlying condition such as homelessness, substance use disorder history, or criminal justice involved behavior that will allow them to be eligible. So the legislature said we really want to target our focus on addressing some of the needs with some of these high need populations that honestly the counties were trying to deal with no federal funding. They were dealing with all county or local government-based funds trying to address this problem. And I think the legislature saw an opportunity to bring in some additional funding from the federal government to cover this population. And because covering this population was not the full Medicaid expansion, the state, if it had done a full Medicaid expansion, at this point in time would have been able to receive probably 100%. That's in 2014, 15, and 16, the expansion population was covered at 100% federal funds. And from that point until 2020, it kind of phased down to the point where now 2020 and beyond, the federal participation is at 90% of every dollar is paid by the federal government. So with the targeted expansion like this, the state's prevailing Medicaid participation rate of roughly 70% was the federal funds that were available for the Medicaid expansion at that point. So the state had to put in I think somewhere around $16 million of state general fund money. There was a hospital assessment or tax that was imposed on the hospitals to help pay for this. But there was a pretty good amount of investment by the legislature and the hospitals at this point just to fund this TAM program and some additional expansion in the parent population on Medicaid. And that helped, I think, make the funding of the eventual expansion much less expensive because the state had already committed resources to that. So then just continuing on here, the ballot initiative, as you are well aware, passed in November of 2018 by a 53 to 47% margin, and then fast forward into the legislative session of 2019. Prop 3, when it passed, had a take effect date of April 1, 2019. So the legislature wanted to make some changes to that, didn't like the full expansion aspect and was hoping for a little more control on the enrollment, and was starting to work on some different waiver options that they were reassured that the federal government was willing to approve, and we'll talk about some of those shortly. But essentially, those waivers, many of those waivers that were sought were not they didn't end up getting approved during the summer of 2019. And so the state moved forward with a partial expansion, excuse me, in April of 2019 up to 100% of the poverty level, hoping to get some additional waivers. Finally, the federal government said they would give some of the waivers, but not all of them. And that is the program that is in place as of January of 2020 moving forward. And if we can move to the next slide here, just in terms of the funding, as I mentioned earlier, the traditional Medicaid program is funded at a 30% contribution from the state and 70% contribution from the federal government. That distribution or share is different in every state. Utah has a generally favorable match rate, but right now on the expansion population, Utah pays $10 and the federal government pays $90 for every dollar expended in the Medicaid expansion population. And as I mentioned earlier in the presentation, that was more favorable even than 90% for the first several years for states who expanded Medicaid. So I'll just pause there and let RyLee jump in.
So a lot of this historical context, as well as the how the Medicaid program is funded, all of this will help kind of orient yourselves as learners of this program and this history of why some of the decisions for the partial expansions were made under SB 96, which was the legislature's redoing of the ballot initiative. So as Michael said, this is how the legacy population is funded, and then this is how the expansion population is funded. And I just want to note here that when we did the partial expansion under SB 96, that was paid for at a 30-70 rate. So Utah was paying 30% of the cost to run that partial expansion, and the feds were matching at 70. But had we done the full Medicaid expansion, we would have only paid 10% of the cost for those expansion population. So, and then just a reminder too, that all of this 90-10 match rate is only for the newly eligible individuals. So our legacy Medicaid population that Michael discussed earlier, pregnant women, children, people with disabilities, they are paid for and will continue to be paid for at this 70-30 match rate. And then just real quick here, as you all probably are aware and voted on, we did increase the state sales tax on all non-food items to pay for the Medicaid expansion under the ballot initiative. So in addition to the hospital funds that Michael discussed on the history slide, they had that pool of funds to pull from, as well as this sales tax increase that Utah voters voted on to help fund the total cost of the Medicaid expansion. So GOMB stands for Governor's Office of Management and Budget. That was their estimate for how much would be raised by the sales tax, taxpayer dollars returned. So we put in $90 million, we get $800 million back from the federal government. And again, just to reiterate, that's money that we were paying into this program since 2010 when the ACA went into effect. So we've been paying into this program for this entire time, but by way of not expanding Medicaid, we have not been getting that money back. So again, that's where you see that 9-to-1 ratio, or that 90-10 match rate. So this is, I will not take credit for this graph here, but this is done by the Utah Department of Health, and you can find this on their Medicaid website. But essentially, this was their work to put a timeline together of what SB 96 entailed. So you can see that there are several different waivers that the state has applied for it, and I've highlighted for you all where we're at currently. So the initial plan was the bridge plan, that was the partial expansion that we've been talking about. So April 1st, 2019, if we just go down this column here, you can see that's when it went into effect. We only expanded up to that 100% of the poverty level. And then at the bottom there, you can see that it was paid for at that 70-30 match rate. So then we moved into a per capita cap plan, where the state was asking for several different waivers to the Medicaid program, which are highlighted here. So they took away hospital presumptive eligibility, they added in a work requirement, they wanted to be able to cap Medicaid enrollment. So essentially the state appropriates a certain amount of funding to cover a certain amount of individuals, and if we go over that appropriation, then we cap enrollment and we don't allow the next person in line who is eligible for Medicaid. Technically, we don't allow them to enroll because we have that cap in place. They have asked for lockout periods for program violations, 12-month continuous eligibility, and this is an interesting one. They did ask for use of federal funds to support housing for extremely low income individuals, likely homeless or people who are on the brink of losing housing, to do that. And they did get approval to use the federal funds for housing supports. So it's not to say that, depending on where you are on the political spectrum, this is kind of a mixed bag of really great things that they're asking for and some things that some might view as detrimental to individuals enrolling in Medicaid. And this plan, the per capita cap plan, they were asking for the 90-10 match rate. So even though they were only going up to 100% of the federal poverty level, they were asking for that enhanced federal match rate. And this is, the legislature in good faith had all indications from the federal government that they would get this approved. And that's why they went back and changed this. And unfortunately, there must have been a change of heart in the administration or some level of disagreement. And so we got the note from the federal government that they would not be giving us the enhanced federal match rate for that partial Medicaid expansion. So that's where you find us now in this fallback plan. We have expanded Medicaid now up to 138% of the federal poverty level. And we have the work requirements, which I'm going to go through in these next few slides. And we do have the 90-10 match rate. So I think those are the biggest takeaways at this point. And I'll pause in case Michael has anything he wants to cover that I left off on this chart.
No, I think that was good. So if we're ready, we'll just move on to the integrated benefit.
Okay.
Okay, so when the expansion took effect last April for individuals in households with incomes up to 100% of the poverty level, they were put into the Medicaid fee-for-service system. Many of you may be aware of the ACOs, as they're known, the Accountable Care Organizations, or contracted health plans, who administer a lot of the benefits for the Medicaid program for the physical health side of the delivery system in many counties, or the prepaid mental health plans that administer the behavioral health benefit, kind of county-based organizations or a consortium of counties that fund a certain organization to provide for the mental health care. And those are kind of parallel systems for the two different types of benefits. But starting January 1st of this year, the state wanted to, what they call, integrate the physical and behavioral health benefit for the expansion population. This doesn't apply to the legacy or traditionally eligible Medicaid populations. This is for only the Medicaid expansion population, and it's only for the Medicaid expansion population in the 4 Wasatch Front counties, Salt Lake, Davis, Utah, and Weber counties. It also does not apply to the TAM population that was an expansion group before the full Medicaid expansion. They're still on a fee-for-service basis. So the contractors for the integrated benefit are the same contractors or health plans that administer the physical health benefit, also known as the ACO. So the university has its health plan, Select Health, Molina, Health Choice. These 4 ACOs also administer this integrated benefit, and sometimes you'll see it referenced in the Utah Medicaid language and policy as MIC or MIC, the Medicaid Integrated Contract. And just to keep them straight from the ACO benefit that is administered, it's based on the population. And so if you're dealing with an individual that is in the category of newly eligible adult and they're in the 4 Wasatch Front counties, then they're going to be enrolled in one of these integrated contracts held by one of the 4 managed care plans. But if you're dealing with someone who is like elderly on Medicaid or a child, they're going to be more in the traditional system where the Medicaid health plan in most counties is going to be their physical health provider, and then there will be a separate behavioral health provider. Here in Salt Lake County, it's Optum on contract through Salt Lake County, and if you're down in Utah County, it's going to be Wasatch Mental Health for the traditional Medicaid package. And this is still a bit of a experiment, not necessarily experiment, but a new concept of hoping to try and have better coordination of care, recognizing the overlap between physical and behavioral health, and by having them all under one contractor to be accountable and in charge of coordinating all of that care, to see if that works better for this particular population than if the individuals enrolled had 2 different contractors trying to manage their care. So this is still a pretty new concept that's being worked out, but something for people to be aware of with the expansion population. Okay, and then in terms of non-traditional and traditional benefits, this is a interesting creation of its own right. Back when the state created the Primary Care Network program in 2002, in order to cover individuals under the PCN program, the state had to make an agreement with the federal government to limit some benefits to the parent population, and with those savings generated enough credit with the federal government, if you will, to create the PCN program. So since the middle of 2002, you've had these 2 benefit packages that over the course of time have more aligned with each other because of other federal legislation that has taken place. The main difference between the two benefits is that the non-traditional coverage has a few more specific limits on services such as occupational therapy, physical therapy, and they may still have some limits on the number of mental health outpatient visits that can happen in a year, although that one may no longer be in effect because of the parity rules that the federal government has implemented. If you want more details on how the state has limits on the non-traditional compared to maybe the traditional benefit package, I've included a link at the bottom of this slide to the state's webpage. There, if you go under their different provider manuals, there is a provider manual specific for non-traditional Medicaid that could provide some additional insights. But here specifically, just wanted to point out that for the expansion adults, the parents will receive non-traditional benefits and are receiving non-traditional benefits and that's consistent with the parent coverage that has predated the Medicaid expansion. And then the childless adults will receive the traditional benefit package. Current legacy Medicaid populations, children, elderly, disabled, pregnant women, those populations all have the traditional benefit. Really, only the parent, caretaker, relative type of enrollment, parent population, they're the only ones that have the non-traditional benefits. Okay, hand it off to RyLee.
So I'm going to speed through these last slides so we can get to questions, but this is a snapshot of where we're at currently. So I just wanted to make sure that you all knew we are enrolling people in Medicaid at this time. And if you have patients or family or friends or whomever, especially now during COVID-19, and we have people who are losing employment and may need that safety net, that is what Medicaid is here for. By no means do we hope that people stay on Medicaid for the duration of their lives, but we do hope that if there is a safety net program for instances that like this that we're going through now. But as of March, we have about 5,000 individuals enrolled in the Targeted Adult Medicaid Program. So again, those are those who are chronically homeless, involved with the criminal justice system, et cetera. We have about 43,000 expansion members who are enrolled in the program. So that's about 14,000 parents and 29,000 adults without children. And the community engagement work requirements started in January of 2020. So newly eligible adults in the Medicaid expansion population have to undergo or participate in the work requirement program, except for the TAM population. So this is just another way to look at those federal poverty level guidelines. So you can see the individuals who are mandated to participate in the work requirement are those in the light gray bar, so the Medicaid expansion population. So this is a new screenshot from the Medicaid application. If any of you assist people in enrollment in Medicaid, you may have seen this, but they've started to screen people as part of the Medicaid application for whether or not they would be exempt from the work requirement. So they're screening if the individual has a mental or physical health issue, if they are a caretaker of a child or a person with a disability, if they're receiving unemployment insurance, enrolled in school, or are a refugee receiving refugee employment services. So this may look familiar. If not, this is part of the Medicaid application currently, or at least was up until COVID, and my last slide talks about that. So the work requirements, if somebody is deemed eligible for Medicaid and they are subject to the work requirement, they have to register for work through the state's Medicaid system. This is my case. They have to complete an evaluation of employment training needs. to determine what services the state can help them with. Think of this as like a resume writing webinar or how to do a job interview webinar. And then they complete the job training modules as determined to be relevant from the state. And then that individual has to apply for employment with at least 48 potential employers. So this is essentially, they can apply through the job portal through the potential employer, and then they go back to the state's My Case website and they put in, I applied for this job on this date and this is the contact. And they have to provide 48 potential employers, otherwise they may lose their Medicaid benefits. So if an individual does not meet an exemption, which I'll show in the next slide or two, and they don't show good cause, which would be like this pandemic, which I'll also show in a slide or two, they will be referred via mail to participate in the Medicaid work requirement program. So this doesn't show up right now, at least on My Case, and people who are managing the care for these individuals aren't going to be able to easily access whether or not that individual is eligible for, or mandated to participate in the work requirement. So again, if you are a case manager on this phone call, it's best that you ask your person that you're case managing, have you received a mailed letter from the state saying that you need to participate in this work requirement? If the individual does not, let's see, so this will be month 1 of the 3-month participation period, and then individuals will be required then to complete participation of the work requirements within a 3-month time period. And if they do not, that is when they would lose their Medicaid benefit. So the state estimated that approximately 70 to 80% of the Medicaid expansion population would meet an exemption. So I'm going to talk about case closure timeline and then we'll go through the exemptions. So if an individual fails to participate by the end of the 3rd month of their Medicaid eligibility, then the Department of Health will send a notice to them saying that the following month they will no longer be eligible for Medicaid. So by not participating in the work requirements, they can lose their Medicaid eligibility. If they do complete all the activities, so they, spend all weekend applying for those 48 jobs and they do their modules, then they can show that they've completed those, and then the state will leave their case open. So the exemption, if an individual is working at least 30 hours a week, if they're age 60 to 64, member of a federally recognized tribe, person with a disability, person who has a caretaker for a child under the age of 6. So you can see that there's a lot of exemptions. And again, the state estimates 70 to 80% of the expansion population will meet an exemption. And again, they are screening for these as part of the Medicaid application process. So good cause exemptions, these are, think of it like a COVID-19. Because there is an ongoing pandemic, this is a good cause exemption, and the state has actually waived the work requirement stipulations under the program. So, if you have a death or a life-changing experience in your family, if you're unable to participate due to lack of internet or transportation, you can apply for a good cause exemption, and then the state can waive the Medicaid work requirement for you. My favorite one, I will just note, is if there are fewer than 48 employers in the individual's geographic area, then I guess they can't meet the work requirement of having to apply for 48 jobs. So employment assistance resources, of course, Department of Workforce Services, United Way 211 has an entire page that is dedicated to employment assistance. Take Care Utah, if you aren't aware of this group, they are a nonprofit organization that helps individuals apply for Medicaid, CHIP, and Marketplace free of cost to the individual, and they are a public benefit that's available to anybody. They speak several languages, and you can reach them through 211, or you can go to takecareutah.org. There's also a nonprofit called People Helping People that does a lot of job training. And of course, we always like to throw out there the U is often hiring, so you can always check out our website. So work requirement court cases and litigation, you might have heard that there's a lot of court cases that have been going on in other states, and why has that not mixed our work requirement here? So Arkansas, Kentucky, and New Hampshire, they have all had a judge strike down their Medicaid work requirements. And however, those happen in court systems that were outside of our circuit court. So therefore, those rulings don't apply to the state of Utah. We have to go through our own litigation process for it to be struck down by a court here. So you'll hear that lawmakers here in the state, when they put this in, they felt ours would uphold a court case because ours is a work effort. They don't lose their benefit if they're not working. All they have to do is apply for those 48 jobs. If they don't get a job at the end of that, that's not what makes them lose their benefit. It's that they have to just make that effort. Okay, so last two here. Sorry, I want to get to questions, but there was also an employer-sponsored insurance that was effective in this SB 96 bill. So if an individual, their income is below that 138% of the federal poverty level, but they do have an employer that offers them insurance, it's just that that premium was expensive for them, the individual can enroll with the state of Utah to have the Utah Department of Health pay their insurance provided by their employer, pay that premium, and then the individual will have their premium ongoing paid by the Utah Department of Health Medicaid program. So that's the employer-sponsored insurance program. I don't know that they've had anybody enroll in this program yet. I haven't heard the Medicaid department mention that, but there is a process set up for an individual to go through that program. And then here's the last one. Due to COVID-19, the Utah Department of Health has suspended the community engagement work requirements. So individuals don't have to go through that process, but once we come through the end of this COVID-19 state of emergency, that will then be reinstated and individuals will have to participate in the work requirement. And then lastly, Utah Medicaid won't close Medicaid and CHIP cases that for individuals that were eligible as of March 18th. They don't have to do the monthly renewal of benefits and through the end of this emergency period. So they won't lose their benefits if they don't report their income. So they'll have that security through the end of this emergency period. And if you haven't visited the Medicaid website, there's a whole page there on COVID-19, and there's a slide specifically for providers. So you can go check that out as well. Okay, we have 6 minutes for questions. So Sarah, will you help us with that?
Absolutely, well done.
Okay.
All right, so there are a number of open questions, and just for anyone who was listening and came in late, you're going to be sending in your questions through Zoom's Q&A function, which is a chat bubble icon near the bottom of your screen. Go ahead and start typing those in, and we'll be getting those answered. Also, just as a quick note, if you didn't hear this in the beginning, make sure to stick around to the end of the questions, because afterwards we are going to be giving away a gift card. We'll be picking from the list of people who are still connected at that point. So stick around. All right, first question that is currently unanswered. Someone says, with the adult expansion, how do they know if they need to bill that through Medicaid or through the U?
So I'll take that. This is Michael. On their Medicaid card or on the eligibility lookup portal, it should tell you if they're enrolled with a accountable care organization, a contracted health plan like the University Health Plan or Select Health, etc. So if it says that on their eligibility, that is where you'll need to send the claim. So if you have questions, I think just a resource for contacting and getting help is the Medicaid Provider Helpline, which is 801-538-6155. And if you are not familiar with the Medicaid online lookup tool for eligibility, they can provide you with some information so that if you're interacting with Medicaid individuals, Medicaid enrolled individuals, that you can see how to look that information up quickly and how to bill those types of claims.
Thank you. And there was a related question. It sounds like there's some people who are experiencing issues where they look up eligibility and they send it in, and then it sounds like they get a denial saying that the claim was sent to the wrong place. So if they're looking up that eligibility on the Medicaid portal, it sounds like it should be telling them where it needs to go. If they have troubles with that, I assume that calling that Medicaid line that you gave would be the correct place to go. Is that
Yeah,
the way?
not having any details of the specific issues, that's where I would start. There are a lot of complexities, sometimes even with the contracted health plans, and then they might have a PBM that's doing the pharmacy claims, and so it can be a little challenging. And so I think if you can try and contact the Medicaid agency and get clear information on the specific client, or at least how to look at those eligibility depictions in the portal, that should help based on
Perfect.
the different types of claims.
Thank you. The next question says, if a person is eligible for expansion Medicaid, do they need to meet the ABD category in order to receive nursing home coverage? Also, please explain the difference between presumptive expansion and expansion. So whoever would like to take that, go ahead.
Yeah, so nursing home care is not a benefit for the expansion. If someone is going to be eligible for a nursing home level of benefit, they will have to meet a level of care standard pointed out here as the ABD, known as aged, blind, and disabled. Aged, blind, and disabled, a reference to some of the existing eligibility categories. So they're essentially going to have to meet one of those ABD categories, which have different levels of asset management, and then they're going to have to meet, like I said, a nursing home level of care in terms of their actual need to have that type of assistance.
Okay, sounds
good. And then
good.
in terms of presumptive expansion and expansion, I've not heard the term presumptive expansion, but there is a term of presumptive eligibility, and currently hospitals can make a presumptive determination on an individual's eligibility if they come in seeking services before the Department of Workforce Services is able to do a full Medicaid eligibility determination. And that's still the case for a number of pregnant women as well within the existing Medicaid program.
Thank you. You did better with remembering that second part of the question than I did. Well done. All right, next question. Let's see if we can fit a few more of these in. It looks like there's someone who is wondering about small mental health providers who have been community partners with the various mental health contractors throughout the years, but they're being left out by the ACOs and are not able to provide services under the new integrated plans in 2020. And I'd like to know more about why that might be.
Okay, yeah, I think for the legacy Medicaid programs, those contracts would still be available for the legacy Medicaid populations, but part of the approach to trying an integrated benefit with the ACOs and having them integrate physical and behavioral health, the state is also holding those contractors accountable for quality and cost considerations. So they're fully at risk for providing the service, meeting the quality of care standards. And so those contractors, the state has allowed them to limit their network, or at least design their network. And it's up to those ACOs or the health plans to determine who participates. And the state has allowed that to happen as part of the experiment.
Thank you for that background. The next question was, has the spend down been eliminated for those up to 133% of the poverty level?
Yeah, so Michael, just so you know, I'm answering a bunch of questions I'm answering all the easy ones and leaving you all the hard ones.
Well, I've tried to answer a few of them myself as I've had occasion, but some of these definitely are easier to answer with a verbal response than trying to type it in. So for a spend down, as I explained in one of the questions I answered, you're essentially looking at the threshold for the eligibility category. Let's say for a disabled individual, you're at 100% of the poverty level. And if their income put them at like 105% of the poverty level for their family size, and let's just say that was $50, that would be the amount of the spend down. For the disabled population, however, the income threshold went up to 133% of poverty level of sorts. Like you can be an individual with a disability and now be eligible for Medicaid at 105% of the poverty level, but your benefit may not be as rich as if you were qualified in the disabled category. So a lot of it depends on which category of eligibility you would be in. But by and large, a lot of people who used to have to pay a spend down prior to the expansion, with those income thresholds being lifted or increased, it took a lot of people who were previously paying a spend down and just made them eligible for Medicaid without a spend down.
Oh, and then one easy one that I can actually take. Someone asked whether a copy of the slides and the questions and answers will be sent out to participants. There is a recording going, and so we'll be sending that recording out to everyone so you can go back and look up things and refresh on areas. So that will be going out. And then if given permission, I can send out slides from RyLee and Michael as well, and that'll be up to them. All right. It looks, oh, what was that?
Oh, I was just going to say absolutely. And the TAM question, if TAM is going to be moving to expansion, I feel that I can answer that for the most part, but want Michael's clarification. So TAM, that program is staying in existence. It's not going away under the new expansion scenario. But what you may have heard, and this is where Michael can clarify, is that the TAM program may go to an RFP and may in the future be managed by an ACO. But at this time, the TAM program is not going away, and it is currently managed by the fee-for-service Medicaid.
That's correct. There's no date that I'm aware of that it's moving under a contracted provider or anything with the timeline of July 1st. I think that's evaluate on an ongoing basis, but I don't think they're ready to move them to a contracted provider yet.
Awesome. All right. It looks like there is a question about who is responsible for managing the ACOs and their payments or lack thereof. It looks like they're having some setup issues and they're wondering what their recourse options are.
Yeah, I think providers, and this is probably going to be a behavioral health provider, we are aware that a lot of the providers, as they've been billing the ACOs and these integrated contracts, that there have been problems with payment. The state is aware of that, and so are the 4 contracted health plans. They're working on these things, but they should contact the state Medicaid agency. I think that provider number I provided earlier will get them in to at least make the state Medicaid agency aware of the problem in the specific case. I think they're generally aware that there have been issues, but I think they're trying to sort through them as quickly as they can. But the state Medicaid agency, the Utah Department of Health, oversees these contracted providers. And I guess again, that number 801-538-6155.
Thank you. And it looks like there was a question about, they would like another quick recap of the nursing home coverage for skilled nursing therapy. They're wondering how that works.
Yeah, so if we're talking about a skilled nursing home, that's one coverage issue, and skilled nursing therapy. I'm going to take a guess that we're talking about skilled nursing home services. So there again, if you've got an individual who is enrolled in Medicaid and they need skilled nursing care, part of it will depend on the anticipated level of time that they will need that care. If they are enrolled with one of the contracted health plans or the ACOs, and they're anticipated to stay in a nursing home less than 30 days, then they will stay enrolled with the health plan, be admitted for whatever their short-term condition is, maybe a rehab stay or something, and then come back in the community. But if they need long-term care in that skilled nursing facility, then they will probably be disenrolled from the accountable care organization and moved into fee-for-service Medicaid based on their level of care.
Thank you very much. All right, we're getting near the end here. There was a question about, can you please address the 90-day grace period from, it looks like January 1st, 2020 through March 31st, 2020, during which out-of-net providers can be paid by the 4 ACOs while in-net providers are found for the recently switched Medicaid clients. What do we do to be able to invoice for those clients at least during the grace period?
Yeah, so here again, it would depend on who the individuals are. So I think as background, because some of these Medicaid patients have been seeing providers from April through December of last year, and starting January, the state transferred their behavioral health or physical health benefit to a different set of providers. This grace period is being instituted. So my thought is, if the medical office can look at the individual Medicaid client, see which health plan they're enrolled with, contact that health plan should be able to work out how to handle this type of out-of-network billing arrangement.
Okay, thank you. All right, and then it looks like, oh, actually, you might have already covered this one. This is someone else who was having some issues with ACO payments and getting some conflicting information, and you did give that contact information for Medicaid. So unless you'd like to add anything to that, I think we'll go ahead and mark that one as done.
Yeah, I think so. I mean, just recognizing there are issues kind of going on with that integrated benefit that people are having challenges with.
Wonderful. And that is actually the end of the questions. So thank you again, RyLee and Michael, for your time and lending us your expertise. And thank you, every one of the attendees who stuck it out to the bitter end. We really appreciate your engagement in all of this, and we hope that you'll continue to join us for these. We're really excited to keep bringing you some content as we're all stuck inside during these times. So keep an eye on uhin.eventbrite.com, and hopefully we'll see you soon. Thank you.
Okay,
Thank you.